A psychiatric mirage. It began on a chaotic Tuesday night when a 22-year-old university student named Maya was brought to the psychiatric emergency room by her family. Over the span of just 4 days, a previously high-achieving, soft-spoken young woman had completely transformed. Her parents described an escalating spiral of severe paranoia, vivid visual hallucinations, and acute insomnia. She was convinced her roommates were monitoring her through the vents. To the initial psychiatry team, it looked like a textbook first-episode acute psychosis. She was started on an atypical antipsychotic, but instead of stabilizing, Maya's condition deteriorated rapidly over the next 48 hours. She became entirely mute, staring blankly into space, completely detached from her surroundings. That was the moment our team was called in for a neurological consultation. The pivot, the body takes over. When we first examined Maya at her bedside, the clinical picture had shifted dramatically from a pure psychiatric disturbance to an obvious organic neurological crisis. While we were testing her reflexes, we observed striking involuntary movements that she could not control. Rhythmic, chewing-like motions of her jaw, facial grimacing, and slow twisting movements of her hands and fingers, classic orofacial and limb dyskinesias. We immediately sat down with her parents to reconstruct the timeline, digging for the missing puzzle pieces. When asked specifically about the days before the behavioral shifts, her mother remembered that Maya had missed classes 2 weeks prior due to what they thought was a simple low-grade fever, headache, and a mild sore throat, the classic viral-like prodrome. Suddenly, the pieces started falling into place. This wasn't a primary psychiatric illness, this was an autoimmune attack on the brain. The diagnostic hunt and the ICU crisis. We rushed Maya for an emergent workup. As is often the case with this condition, the early objective data tried to mislead us. Brain MRI, the standard T2 and FLAIR sequences came back entirely unrevealing. No structural lesions, no obvious swelling, lumbar puncture. The cerebrospinal fluid, CSF, gave us our first real warning sign, showing a lymphocytic pleocytosis, an elevated white blood cell count of 45 cells per microliter, signaling active intense inflammation within the central nervous system. Before we could even finish processing the CSF, Maya suffered a generalized tonic-clonic seizure. Immediately following the seizure, her autonomic nervous system began to fracture. Her heart rate fluctuated wildly between extreme tachycardia, 140 bpm, and profound bradycardia, 40 bpm, and her oxygen saturation began to plummet. She had developed central hypoventilation. Her brainstem was forgetting to tell her lungs to breathe. We urgently transferred her to the neurological ICU, intubated her, and placed her on mechanical ventilation. The breakthrough, while Maya was sedated and paralyzed on the ventilator, we hooked her up to a continuous video EEG to monitor for subclinical status epilepticus. A few hours into the recording, the tracing revealed the definitive, rare clue we were looking for. Riding across the slow, rhythmic delta waves of her encephalopathic brainwaves were bursts of rapid, sharp beta activity. It was a flawless manifestation of the extreme delta brush EDB pattern. EEG tracing visualization. With EDB staring back at us from the monitor, we didn't wait for the antibody panels to return. We immediately initiated empiric aggressive first-line immunotherapy. High-dose intravenous methylprednisolone 1g daily, combined with intravenous immunoglobulin, IVIG. 2 days later, the laboratory confirmed our diagnosis. Maya's CSF was strongly positive for anti-GLUN1 IgG antibodies. Hunting the trigger, knowing that roughly 40% of adult women with anti-Nmdar encephalitis harbor an underlying tumor driving the immune response, we ordered a pelvic ultrasound and CT scan of her abdomen and pelvis. The imaging revealed exactly what we suspected, a 4.5 centimeters well-differentiated right ovarian teratoma. The tumor contained neural tissue. Maya's immune system had rightfully mounted an attack against the foreign brain tissue inside the cyst, but the resulting antibodies were now cross-reacting and aggressively internalizing the NMDA receptors in her actual brain. The outcome? Our gynecological oncology colleagues performed a prompt, uncomplicated laparoscopic resection of the teratoma. The recovery from anti-NMDAR encephalitis is notoriously slow, as the brain requires time to rebuild and restore its internalized surface receptors. Maya remained on mechanical ventilation in our ICU for nearly 3 weeks. However, with the tumor removed and the antibody production halted, the downward spiral stopped. Slowly, the autonomic instability settled. Then the dyskinesias faded. By week 4, Maya was extubated, and the mute curtain lifted, Her first words were fragmented, and her short-term memory was profoundly impaired, but she was entirely present. Following a structured course of inpatient neurorehabilitation, Maya walked out of our facility 3 months later, on track for a near-complete cognitive recovery.